Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of cutaneous ALK-negative anaplastic large cell lymphoma. This is a case of a 42-year-old male patient who presented with left leg skin lesion from which the biopsy was obtained. And as you can see, this is a generous biopsy. Actually, we have here the epidermis, and then we have an infiltrate that dissects down into the deeper part of the dermis. Now, just zooming in a little bit, we have here hyperkeratosis, we have some filling of the epidermis, and then we have this very much monotonous infiltrate that on higher power magnification shows a proliferation of cells with vesicular nucleus, prominent nucleolus, some acidophilic cytoplasm, not much in the way of only occasional what looks like embryo cells, only occasional ones, not really very prominent. And then we can see many mitotic and apoptotic figures. And on just zooming in further into the infiltrate, again, we have a kind of monotonous infiltrate with this cells with the vesicular nuclei, very prominent nucleoli, and abundance of apoptosis here and there. Wherever you go, you will find apoptotic figures, and then more of the same, showing the dissection in between the fibers. And again, here we have apoptotic figures, many apoptotic figures, and mitosis, including abnormal forms, not really much in the way of embryo cells, which are typically seen with the ALK-positive anaplastic large cell lymphoma. And just to give you the sense of the infiltration, this is just the the superficial part where we have of the dermis, where we have the collagen fibers, and then we have the cells dissecting in between. Here is showing the same appearance of the tumor cells. I wanted just you to have the sense of the monotony of the tumor cell infiltrate, and here towards the deeper aspect of the dermis, where we have again this infiltration by these tumor cells. And this appearance would really bring many important differential diagnoses into consideration, one of which should always be lymphoma, whether this is anaplastic positive or negative lymphoma. And the CD3 is frequently negative in anaplastic ALK-negative anaplastic large cell lymphoma. Something like 50% of the cases are negative, and this should not sway you from making or considering this important differential diagnosis, because around 50% of the cases are CD3 negative. What is really important is always to remember to use something like CD43. I like it a lot. It really is a wide spectrum immunohistochemistry for hematolymphoid markers in general. Even the cases that are CD45 negative can still be positive with CD43. So always include CD43 in your panel in case that you are suspicious of a hematolymphoid infiltrate, because of the wide spectrum or the wide coverage of antigenicity with the CD43. Now, CD2 showed this strange dot-like cytoplasmic positivity, but what was really important is that while the tumor cells were CD3 negative, they were CD5 diffusely strongly positive, and CD7 is negative as well. So remember, with anaplastic lymphomas, in particular, the ALK-negative, but also the ALK-positive can be negative for, they show loss of the some of the CDs that are specific for the T cells, including the CD3, sometimes CD5, or even CD7. So in this particular case, the tumor is thus far staining with CD43, which tells us that this is a hematolymphoid proliferation, and this is CD5 positive. which would favor a T cell rather than other type of inflammatory hematolymphoid infiltrate. But remember, these can also be negative frequently for CD3 and CD7, so this should not sway you away from the diagnosis. Now, importantly, always to consider CD4 and CD8. Now, the ALK-negative lymphomas are anaplastic lymphomas are CD4 positive by definition. Now, at this stage, one also should consider other differential diagnoses. Remember that CD4 can also be positive or in some histiocytic tumors, so we should keep this in mind as well when we work out our case. Now, CD8 in contrast is completely negative. So far, this is a CD43 positive, CD5 positive, CD4 positive tumorous infiltrate, and the CD30 strong diffuse positivity of almost every single cell that is present in the infiltrate, and this should be extremely supportive in rendering or in narrowing, I have to say at this stage, the differential diagnosis. So the positivity is usually cytoplasmic with some accentuation of the Golgi apparatus, and of course we have to do the ALK stain, and ALK stain is completely negative. Because of this, this is considered to be an ALK-negative anaplastic large cell lymphoma. Now, typically the ALK-negative anaplastic large cell lymphoma, in particular the cutaneous tumors, are EMA negative. So again, this in a way contrasts with the ALK-positive anaplastic large cell lymphoma. Remember, this pattern, it's quite unusual, but if you have it in your mind in the differential diagnosis, you will reach into the proper diagnosis. Now, granzyme sometimes can show some positivity. In this particular case, there were some scattered positive cells here and there, not really much of an impressive immune stain, and CD56 was at large negative, because we have to consider the possibility of NK extranasal NK type of lymphoma, and because of the strong CD15 positivity, CD30 positivity, CD15 has always to be done in order to exclude Hodgkin's lymphoma, although I have to say cutaneous involvement in this pattern is quite unusual in Hodgkin's lymphoma. So the final diagnosis in this case is an ALK-negative anaplastic large cell lymphoma occurring in the skin, presenting as a skin lesion in the leg of an adult male patient. Remember that whenever you have this dense infiltrate, one of the important differential diagnoses that you have to consider is lymphoma, in particular anaplastic lymphoma. Remember that with the cutaneous anaplastic lymphomas, especially the ALK-negative, the EMA would be negative, CD3 might be negative, CD7 might be negative, and this might sway you away from the diagnosis. So you have to use a wider coverage marker. In this particular case, it was CD43, which really hinted to the diagnosis. Then you have always to do CD4, which is positive in this case. And remember that EMA in anaplastic, ALK-negative anaplastic lymphomas, in particular in the skin, are usually negative for EMA. I hope you find this tip useful in your daily practice. Thank you.